Good day to everyone. My name is C.B. Mamaril, and on behalf of the Systems for Action National Coordinating Center, it's my pleasure to welcome all of you to today's S4A Research and Progress webinar on strategies to achieve alignment, collaboration, and synergy across delivery and financing systems. And today's topic will be on the Comprehensive Care, Community, and Culture Program. Before we get started, we'd like to acknowledge the funding and support of the Robert Wood Johnson Foundation. And we'd also like to remind everyone in the audience that you can type in your questions at any time during the webinar at the chat box in the lower left-hand corner of your screen, and we'll try to get to your questions after the presentation and commentary. So it's my pleasure to introduce to you our speaker for today, Dr. David Meltzer. He is Chief of the Section of Hospital Medicine, Director of the Center for Health and the Social Sciences in the University of Chicago Urban Health Lab, and Chair of the Committee on Clinical and Translational Science at the University of Chicago. David's also the Fannie L. Pritzker Professor in the Department of Medicine, the Harris School of Public Policy Studies, and the Department of Economics at the University of Chicago. David's research explores problems in health economics and public policy with a focus on the theoretical foundations of medical cost-effectiveness analysis and the cost and quality of hospital care. David's work on the effects of improved continuity in the doctor-patient relationship between the inpatient and outpatient settings on Medicare patient costs and outcomes led to the creation of the Comprehensive Care, Community, and Culture Program, which addresses social determinants of health within a coordinated care model. David helps lead a CTSA-funded Chicago Learning Research Network and a PCORI-funded Chicago Area Patient-Centered Outcomes Research Project also. David also has received numerous research and mentoring awards and is a member of the National Academy of Medicine. So with that, I'd like to turn it over to you, David.
Great, thanks, CB, and thanks everyone for joining. It's a pleasure to talk about this work, and today I'll be talking certainly about our Comprehensive Care, Community, and Culture Program, which is the focus of our Systems for Action project, but more broadly about some of our work on improving care for patients at increased risk of hospitalization, in particular the Comprehensive Care Physician Program, that in a way forms the basis for the work we're doing with the Comprehensive Care, Community, and Culture Program, or as we often call it, C4P. And of course I want to acknowledge the support of the Robert Wood Johnson Foundation for this work primarily, and also note that it builds on work supported by the Centers for Medicare and Medicaid Services, the Donahue Foundation, and some local support here at the University of Chicago. I also want to acknowledge my close colleagues in this, Liz Nida, who's joining me here today, and Harold Pollack and a whole crew of others. So let me leap into the substance. So the challenge that we are trying to address in a lot of ways in improving care through these programs has to be understood in the context of the broader goals to improve healthcare and control costs, and of course the Affordable Care Act. And if you think about the Affordable Care Act, of course, its goal in one sense is to make healthcare more affordable. Some of that is to make it more affordable for individuals, for example, by expanding insurance. But another part of it is really to make healthcare more affordable for society. And there are a whole series of strategies that the ACA is engaged in to try to do that. But before I leap into those, I think it's really important to sort of frame this in the broad arc of U.S. healthcare expenditures. On the left there, you see a graph showing the growth in healthcare spending in the U.S. Historically and over time. And as you look at that line that sort of seems to go ever upwards, it's easy to believe that public policies don't necessarily change, or that will never change. But in fact, public policies can make a big difference. And the second graph there shows growth in hospital expenditures in the U.S. in the years preceding the institution of the Medicare prospective payment system, and then in the years afterwards, with healthcare spending dropping from hospital spending dropping from annual growth rates of around 14-15% down to more like 5%. So public policies can make a difference. But I think if there's one thing that we've learned over the course of the past half century of studying and trying to control healthcare costs, that most important thing is that healthcare spending is wildly concentrated. This is a graph that shows the distribution of Medicare beneficiaries and the distribution of healthcare expenditures. And one striking thing is that sort of the top 25% of patients are essentially responsible for 85% of the spending. And that has huge implications. First of all, it says you're never going to control spending unless you control spending among those high-cost beneficiaries. And in fact, this project will very much focus on that. It also has a reciprocal implication, which is that if you are focused on the other 75%, the low acuity people, it's going to be a whole lot harder to have a big impact on healthcare spending. So let me turn to the ACA and some of its efforts to try to control healthcare costs. So there are a variety of things in the ACA that try to do that. Increased emphasis on prevention. A great idea and certainly good for health, but unfortunately not great evidence that it often decreases costs. Comparative effectiveness research, certainly a good idea in general, but as it's been implemented in the United States, with PCORI and others banned from thinking about costs, there are lots of reasons to believe that that's going to struggle in finding ways to save money. Care integration is obviously an incredibly important challenge, and initiatives like the patient-centered medical home, would hope to reduce costs. It's been challenging, and I think one of the reasons why is that care integration is important regardless of where you are in the care spectrum, whether you're, sick and costly or relatively healthy. And it's very easy to target care integration efforts towards things that will necessarily save money for political and other reasons. And so there are reasons for concern that that's not going to be an easy fix for us. Then you've got bundling, capitation, accountable care organizations, a bunch of incentives to decrease costs. And there's lots of evidence, including the history of Medicare prospective payment, that suggests that can really work. The challenge is it sort of begs the question of how you actually do it and what it does to quality. And here's where the Center for Medicare and Medicaid Innovation comes in. $1 billion a year for 10 years, the ability of the Secretary of Health and Human Services to implement what works. And the original work we did on the Comprehensive Care Physician Program, or CCP program, grew out of that. And then finally, reinvestment in primary care. There's lots of evidence to suggest that specialization in the United States has grown extraordinarily, and that specialization may raise costs and even worsen outcomes. So there's been a belief that if we can sort of promote the growth of general medicine and generalist practice in general, we may be able to improve outcomes. And in some sense, our work is tied to that, and that's been a long-standing interest of my own work. So let me move on and sort of frame this in terms of the growth of the field of hospital medicine, which really is the foundation for what we're talking about in a variety of ways. So traditionally in the United States, as I think most everyone on the call knows, people have had a primary care doctor. They care for them in clinic and in the hospital for the general medicine problems. These doctors would see patients, their own patients in the hospital in the morning, and then in the afternoon go to clinic. And with this, there's been incredible emphasis on continuity of care and the value of the doctor-patient relationship. Now, beginning in the 1990s, this all began to change with the rapid growth of hospitalists as a medical specialty, defined as doctors who spend at least 25% of their care in inpatient medicine, and typically much more than that. And there are now 30 or 40,000 hospitalists in the U.S., the fastest growing medical specialty in the history of the country. And the question we've been interested in is this change in specialization a desirable one? And the theoretical frame we've seen this through is, on the one hand, the advantages of specialization, inpatient focus, expertise in hospital care, presence in the hospital. Those are the advantages, but also disadvantages. And in particular, the loss of the doctor-patient relationship with this division of inpatient and outpatient care. And I'll come back to that later. The theory then is that the optimal degree of specialization sort of balances these benefits and costs. And this theory has roots in economic theory, going back to Adam Smith and the Wealth of Nations, in medical theories of professionalism and the doctor-patient relationship, such as Francis Peabody's work, which argued on the importance of sort of knowing the whole patient, but also recognize the importance of technical and specialized expertise, and even popular theories like the famous 1970s television doctor Marcus Welby, who on the one hand was the doctor who sort of addressed all the patient's problems, but on the other hand, struggled with specialized knowledge and the complexity of trying to do everything. There's an additional theoretical framework that I think may be less familiar to people and is very important. And in this sort of framework, rather than viewing the optimal specialization as balancing these benefits and costs, what you try to do is sort of adjust the model to minimize those tensions between advantages and disadvantages of specialization, the problems of coordination. And you may do that by improving handoffs, reducing the number of handoffs. This has sometimes been called in the literature an adaptive organization perspective. And what this means is when you have very high returns to specialization, so you want to be specialized, but also very high coordination costs, so that being specialized leads to these coordination problems, what you do is you focus your product to try to reduce the needs for coordination. In other words, build a care model around people who will need coordination so that that model itself can handle it. This has been called sometimes the solution shop by Clay Christensen at Harvard Business School. In a lot of ways, this is going to frame what we talk about in the comprehensive care program. Now, as we've been looking at these problems, one of the other things that we've wondered about is not just are hospitalists a good thing, but why did they grow? And one early theory was that hospitalists grew to meet the needs of hospital care. These doctors would have the incentive and ability to reduce hospital costs and improve outcomes. But the evidence has turned out to be really limited that they produce large changes in either of these. Some benefits, but really modest. And so this is led us to wonder, why is it that hospitalists grew if they really weren't necessarily so much better? And the conclusion we've come to is that they grew to meet the needs of ambulatory care. And the idea was that over time, traditional doctors had fewer patients in the hospital on any given day. Their clinics became busier and busier with patients trying to stay well and seeking prevention. They could fill their whole day with these patients and almost never have a patient in the hospital. So when they had a patient in the hospital, it just wasn't worth the trip for them to drive in to see that one person. This graph on the right shows some data that supports this hypothesis and describes an 80% decline over about a 20-year period in the volume of hospital visits for American generalists compared to the number of ambulatory visits. And so they just didn't have the volume to justify this. And as these physicians organized into groups, encouraged specialization where some doctors would go to the hospital and others would stay in clinic. And that, of course, is the growth of the hospitalist movement. Well, what I just described to you is a theory. And we've actually tested this theory using economic models to try to see whether its predictions are supported in the data. And to do this, we model the time cost of physicians practicing in two models of care. First, the traditional model where the internist spends their time seeing patients in the hospital and clinic and then has to drive back and forth between the hospital and the clinic. And this sort of newer hospitalist primary care model where the hospitalist spends their time seeing patients in the hospital, but they also have to now communicate with the PCP. And the PCP spends their time in clinic, but now they have to communicate with the hospitalist. So the difference in cost between these PCP hospitalist model versus the traditional model is driven by the difference between these transport costs on the one hand relative to communication costs on the other. And when the math there sort of describes this mathematically, and you get a number of predictions. In particular, that the cost of the PCP hospitalist model relative to the traditional model will fall as the rate of admissions fall relative to ambulatory visits, and I just sort of told you that it happened, as communication costs decline. Again, better telecommunications, electronic health records, making it easier to just call in from the primary care office rather than going to the hospital to see the patients. Transport costs rise, think, complicated hospital parking lots and traffic. And also, importantly, as physician work hours decline, which has been the case particularly in general internal medicine for male doctors, for female doctors, sort of across the board. And so all these pressures pushed us towards these models. And the pictures there on the right are all pictures from the Marcus Welby TV series of these sort of four elements: him seeing a healthy patient, him on the phone, him happy in his car, and a young doctor who took over his practice and liked to ride motorcycles and work short hours. So we actually took data on all these measures of it, admission rates, communication costs, transport costs, physician work hours, and using data from the community tracking study, we're able to show that we could actually predict which primary care doctors decided to give up their hospital practices and turn them over to hospitalists based on these factors. So we concluded that sort of hospitalists grew not really because they were better, but because it was easier for doctors. Now, if you believe that, there's reason for anxiety about what this could do to patients, particularly this loss of continuity. And the reason to worry is that there's a really striking literature on the value of the doctor-patient relationship in the hospital setting. So it emphasizes trust, interpersonal relationships, communication between the doctor and the patient, knowledge of the patient. We know patients value seeing their own doctor in the hospital. They won't necessarily pay a lot of money for it, but they clearly say they value it and are willing to pay some. Maybe more striking, there are some observational studies that show lower costs and better outcomes with continuity of care. Medicare patients who are cared for by their PCP for more than 10 years have 15% lower Medicare costs. Lung cancer patients cared for by their own doctor in their terminal hospitalization have 25% lower odds of ICU use, presumably futile care. There's one experimental study, so the two studies that's described are observational and they can be critiqued based on confounding, but this experimental study is really striking. Jack Wasson in the 1980s randomized almost 800 complex patients in the VA, either to see the same doctor in every clinic visit or a completely different doctor in each primary care visit. And what they found is in the continuous care group, there were 49% lower emergent hospitalizations, 38% lower hospital days, and 74% lower ICU days. I mean, really striking results in this randomized trial. So what this suggests is that these discontinuities can be harmful and costly, especially for these complex, frequently hospitalized patients. And it raises this question of whether better care coordination between the inpatient and outpatient settings could improve outcomes. That idea is not a new one. In fact, Medicare has been thinking about that idea of improving care coordination between the inpatient and outpatient setting for years. And in January of 2012, Medicare, the Congressional Budget Office, put out a report summarizing Medicare's experience in care coordination interventions. And unfortunately, it's not totally encouraging. On average, they found the studies, some prevented hospitalization, but many didn't. On average, they didn't save money. The programs worked a little better when fees were at risk. They worked a little better when there was substantial direct interaction between care managers and physicians and between care managers and patients. But even then, they weren't compelling. One does get the sense that one of the challenges in these is a sort of game of telephone where you've got inpatient doctors, care coordinators, outpatient doctors, patients, and the costs and difficulties of those communications really can be overwhelming. There were a number of other lessons that came from this review, sort of target high-risk enrollees, gather timely data on the use of care, especially around hospital admissions, focus on transitions of care, use team-based care, and keep the cost of the intervention low. And these are all things we really tried to do in designing this program. I want to target this idea of keeping the cost of the intervention low. In the bottom right corner there, you see a graph that sort of talks about healthcare spending, and the bars there are sort of on what we have now, which is a little bit of money spent on ambulatory care and a lot of money spent on hospitalist care. And our goal is to sort of shrink that bar. Now, we try to do it by investing in care coordination, which means we have to allocate money to that. It's hard to shrink ambulatory care. We want that to keep people out of the hospital. So what that means is you have to shrink hospital care a lot if you're actually going to save money. And I think this is one of the reasons why these models haven't worked as hoped in decreasing spending. So the goal really, if you could, would be somehow to improve care coordination without adding a lot of costs. And this is where the model that we developed for the comprehensive care physician program came in. We sort of take a tailored approach to care, where we stratify patients according to their expected hospital use. And if they're at high expected hospital use, they get one of these comprehensive care physicians who can see them both in clinic and in the hospital. So their practice is focused on these patients at high risk of hospitalization so that they can have a small enough clinic panel that they can see those patients only in the afternoon and still have the mornings free to see patients in the hospital and, of course, have enough patients in the hospital to justify that because they're seeing high-risk patients. Then for the patients who are low expected hospital use, they get a traditional ambulatory-based primary care doctor, and in the rare instance they're hospitalized, they get a hospitalist. But that doesn't happen very often. What's the advantages for the patients who end up with the CCP model? The most frequently hospitalized patients get their own doctor in both settings with all the advantages of continuity of care, much easier for the doctor as well. All hospitalized patients get doctors with significant hospital experience and presence, so they have the benefits of being a hospitalist, could even be a specialist. Patients get to choose their doctor, which they don't for hospitalists typically. This can be a practical model for the physician with a small panel size of high acuity patients. You can do this in a patient-centered medical home with bundling or readmission penalties. And if you have a small a hospital that needs to be filled beds, you can build a small primary care base. And still do that. What are some of the challenges? Will enough patients be willing to switch? Will doctors let patients switch? Will doctors do the job? Can it even be economically viable? So in 2012, we got funded by Medicare to do this. We recruited a diverse population, including more than half dual eligibles with a median family income of less than $25,000, and we designed a randomized trial. These are some of the key elements of that original study. We focused on high-cost patients, expected to spend at least 10 days a year in the hospital, spending often $100,000 per year or more. We maximize the direct interaction with the comprehensive care physician by keeping the panel size small at 200 patients per doctor. They spend their morning on the wards, a little time off in the middle of the day, and then in the afternoon in clinic. We built an tight interdisciplinary team around these 5 CCPs and RN, LPN, social worker. We kept the costs low with these small teams. We focused on care transitions with simple IT to support that, like pages if the patient presents in the ER. Prepared for shared savings, and we've now moved towards that. We try to design and support sustainable roles for the care team, particularly given the complexity of these patients. We used rapid cycle innovation techniques with frequent data-driven meetings that engaged the leaders needed to support the program. And then finally, rigorous evaluation. We designed this as a 2,000-person RCT with aims looking at better care, better health, and lower costs. I have a lot of those results. I'm not able to present them publicly today, but I will just say that it looks extremely encouraging in sort of all these dimensions. Let me tell you a little bit about the future and then set up the C4P program. So we'll be completing 1-year follow-up in June of 2017, and which has just happened, and so we're beginning analysis of data, and then we're planning to do 3-year follow-up. We're addressing longer-term issues like the financial models for expansion and sustainability, including under fee-for-service with risk-based arrangement. We've recently become an ACO, some managed care contracts. We're working with CMS for a physician-focused payment model to support this, and looking at some special high-need populations. And we've been partnering with a number of institutions around the U.S. and even internationally who've become interested in the model and are now trying forms of it. And we're starting to form a learning collaborative supported by Medicare and with partnership with Project ECHO to try to educate other institutions in how to do this. We are also interested in sort of building networks that combine multiple hospitals in this, and we're beginning to do this in our own setting in particular with sort of hospitals as hubs and other hospitals and clinics as spokes. And our health systems recently purchased a hospital called Ingalls, which may be our first partner in sort of doing that. So let me now sort of turn to the challenge of the model, and this really sets up the C4P program. One of the big challenges, as successful as the model has been, is that there's a group of about 30% of patients who are randomized to CCP who really don't engage fully. They either don't make appointments, they make the appointments but don't keep them, or just don't engage in other ways. And all of these sort of failures to engage patients are opportunities to better benefit patients, improve care, if we can figure out how to engage them. And in fact, the ones who don't engage are often very high utilizers. Why do they not engage? There's no single predictor, but many of them have little social support and a history of low engagement. And so we've tried to get a patient perspective on why it is they don't engage. So we go to them. They won't come to focus groups, of course, because they're not engaged. So we see them in the ER, we see them in the hospital, and we ask, what could we do to better engage you? And these are some of the barriers we hear about, things like transportation, not knowing how to navigate it, practical things, childcare. But a striking comment is sort of mood. I just don't feel up to it, not an uncommon statement. And we ask them what would help. These themes kind of come up again. They talk about transport and other things. But once you ask them what that means, they say things like, if I had transportation, I wouldn't have a problem getting up. I don't know if it's just depression or what, but a lot of times I just don't want to be bothered. It's been like that a lot. Or at the bottom of the slide there, what else would help? Well, nothing really. It's nothing you guys are doing. I just have to get in the right mindset and calm in when I need to. I really prefer to go out and walk or something different than spend my time at the doctor. So there's this sense of the sort of building of relationships and the psychological barriers that are critical. So with that in mind, we've designed the Comprehensive Care Community and Culture Program, or C4P. There are really three main elements of it. First, systematic assessment of unmet needs. I'll come back to that in a minute and tell you how we're approaching it. The second, once we address those needs, is a community health worker program that seeks to engage the patient in their community home and deepen our understanding of their social needs and help them navigate the system and connect them to the team. We've tried to hire community members. These are not disease-focused community health workers, but we've linked them closely to the team, and we've worked with experts in the Sinai Health System who have a lot of experience working with community health workers. The third component of the program, rather, is the Artful Living program. And the idea here is a sort of community arts and culture program which really engages patients with others and with the clinical team through enjoyable things like music, arts, theater, and so on, things that promote self-efficacy, exercise, cooking, crafts, information about social determinants, and really through these activities to explore and share values that enhance life and health, and developing things like narrative opportunities, things like the Stanford Letter Project and Photo Voice. So in our RWJ study, we've really, our goals have been to establish the program and then to pilot and begin to perform a randomized trial looking at the comparative effects of standard care versus CCP versus C4P on engagement, the sort of triple aim of better care, better health, and lower costs, and also the idea of goal attainment, finding out what's important to patients and seeing whether we can accomplish that goal. Let me spend a few minutes just talking about the unmet social needs data. We use a tool developed by Health Leads that identifies 16 different domains, and you can see them listed here on the slide. And then we added a 17th, which was spiritual or religious support. The questions just basically ask, do you have any need in this area? And then once we learn that they have a need, it then leads to a conversation to try to understand what that specific need is. And then that will ultimately guide our assistance towards them. This shows you the distribution of unmet needs, and there are some really fascinating findings here. So the table shows the number of respondents and the number of needs they have. So about 50% of respondents only have 0 to 2 unmet needs. But interestingly, that accounts for only 10% of all the unmet needs. The other 50% of respondents account for 90% of unmet needs. And 29% of the respondents have 5 or more needs, accounting for 68% of the unmet needs. So one of the striking things here is, I just told you these folks are challenged in engaging in resources, and yet they have many, many needs. So if you try to take a patient who has 5 needs and refer them to 5 different organizations for different needs, you can imagine your probability of success is not going to be great. And that's where we think sort of the navigation and community health worker work is important. Now, the other sort of thing you could think is, well, maybe we should just focus on a few needs. And you can see that some are more prevalent than others, particularly in respondents with many needs. But it turns out that even if you solved all of the top 5 needs, that would only address half of all the unmet needs. So just focusing on a few doesn't really work. You could focus on clusters of needs, and we do see clusters like healthy eating clusters with physical activities and engaging in enjoyable activities. There's sort of a financial cluster as well. So, those may be some strategies, but where it leaves us ultimately is that we really think we need to build patient-centered approaches to address these, build programming based on clusters, mobilize the community health workers and social workers to address these jointly at the patient level, and then in the long run, really thinking about how to defragment social service supports when referral is necessary, so you can refer to organizations that could meet as many of these needs as possible. One other really interesting part of the data that we have from this pilot is that we are measuring changes in unmet needs over time. This is important on the one hand because it's an outcome measure, and we'd like ultimately to be able to compare changes in unmet needs over time in the C4P, CCP, and standard care arms. Our sample size is too small right now to do that, but already the data is giving us some important guidance for program design. So one of the things we see, for example, in the table below, you can see that we have unmet needs followed 3 months after they're originally identified. And what you can see is that needs that are unmet at baseline tend to still be unmet, in the future. And needs that are met at baseline, though, actually have a non-trivial prevalence of development. And it's interesting. So at any point in time, a substantial fraction of the unmet needs are actually new. The other thing that's really interesting, if you look in the table, if you look at the resolution of unmet needs based on how many needs at baseline, what you see is the people with more needs are both somewhat more likely to continue to have those needs and much more likely to have new needs develop. And as you can understand how the dynamics of unmet needs feed on themselves. And so sort of the more unmet needs you have, the more you're going to get. And this is both discouraging in a sense and encouraging to the extent we can turn things around and make progress. Let me talk briefly about the Artful Living program, the sort of community-based arts and culture program. So we're still really very much learning here, and we're taking an approach of iterative experimentation that deeply involves both faculty and patient advisory group. We ask patients, what would interest you? And, we get a variety of answers, family-friendly activities, opportunities to socialize, music, and so on. We ask about barriers. We hear practical things like parking, being busy, lack of family interest. And then importantly, again, these psychological barriers. What's the barrier me? I have an issue with overthinking things so much. Again, we think sort of the relationship component is critical. So we try to engage our community health workers in partnership with this Artful Living program to try to pull people in and help them feel supported in coming to these activities. How have we done? Well, we're making, I think, real progress. We've done a variety of activities in social and arts, social determinants in health. The participation has really been growing. We've had up to 20% of the whole study population express interest in any given event. A lot of patients say they're interested and then don't show up. They may be in the hospital or weather's bad or transport problems. We found things like having events during clinic days helps a little bit because they can come. But other things have been even more powerful. Bringing family has turned out to work really well. And one of the most striking things is if we plan an event on days when school is canceled, very often parents or grandparents will bring their children. And that's been really great. So we actually target those days now for activities. We've built a real core of attendees, and we've gotten a lot of positive feedback. And we're now continuing to sort of iteratively experiment and grow as the program reaches critical mass. We've enrolled about 300 patients in our pilot, but the C4P part of it's really only about 100 patients. And so as we add the community health workers and engage them more, we're doing better. And we've had actually 20% of patients in the program attended our most recent barbecue. So we've, of course, been thinking about sustainability and how will that work. Well, most importantly, it works if it works for our patients, so engaging them in activities and making the activities convenient for them and promoting their sense of self-efficacy and wanting to engage in them. We try to use community resources. They're available and often available for free or at very low cost, and that has been very effective for us. And we've also tried to begin to work to promote integrated delivery by social service organizations. And that's really in its just very infancy, and I think our area for future work. We've recently identified the University of Chicago's Civic Leadership Academy, which actually trains community leaders to be more effective in leading their organization. And we're hopeful we're going to partner with them to try to work with local organizations to try to address this problem of defragmenting care. Money is always an issue. We've found some nice opportunities for sustainable philanthropy with small donors and arts foundations, and we've even had a few grateful patients who've given us some resources. But ultimately, as I said, the money is really in total health care spending, and so probably the most important thing for long-term sustainability is to build a business case to payers and health systems. We've tried to optimize the use of existing resources that keep the program cheap, and then we're doing this randomized trial to hopefully show cost savings and efficiencies, which take a variety of forms, including minimizing no-shows even under fee-for-service. And as our randomized trials develop, we're thinking about actually changes in our control group. Our institution has recently become an accountable care organization. They're investing in care management and probably going to adopt a form of care management like what's been used at Partners that Tim Ferriss led, and we'll probably try to compare to that. And based on the preliminary results we've seen on cost savings, we think we actually can produce much larger savings for the healthcare system and make this case. And so far, the health system seems to agree because they are eagerly partnering with us to try to integrate us into their activities. So let me just, in closing, thank RWJ and our other funders, the members of our clinical and research team, and my colleagues here at the University of Chicago and in the community who've all helped make this possible, and most importantly, of course, their patients and their families for engaging with us and trusting us with their care and working with us to try to make care better. So let me stop there, and I imagine turn it over to Bill.
Thank you so much, Dave. Thank you so much, David. And Anne, is Bill on the line already before I introduce him?
Yes, I am.
Okay, excellent, Dr. Riley. Okay. Well, it's my pleasure to introduce you our commentator for today, Dr. William Riley. He is a professor in the School for the Science of Healthcare Delivery at Arizona State University, where he teaches process engineering, health finance, and healthcare quality and safety design. Bill previously served as the Associate Dean for the School of Public Health at the University of Minnesota and currently serves as the Director of the National Safety Net Advancement Center. Bill brings 25 years of senior executive experience in healthcare organizations, including serving as President and CEO of Pacific Medical Center in Seattle, Washington, CEO of Aspen Medical Group in St. Paul, Minnesota, Senior Vice President at Blue Cross Blue Shield Minnesota in St. Paul, and Senior Vice President of St. Paul Ramsey Medical Center Ramsey Clinic. Bill is the author of more than 60 articles related to quality management, patient safety, and healthcare management, and has co-authored 2 books on performance improvement in healthcare, and is a past chair of the Public Health Accreditation Board. So with that, I'll turn over the comments to you, Bill.
CB, thanks very much. David, thank you for that outstanding presentation. And even more important, thank you for all the really important work you are doing in terms of improving quality and efficiency in healthcare. There were so many important concepts, David, that you incorporated and integrated into your presentation. Each of them is meritorious of a webinar all by itself. So again, thank you. It's hard to prioritize which areas to comment on, but I think because there was so much and it's such a rich area that you provided for us today. But I'm very interested. What I keep bumping into, David, is your reference to the disruptive innovation and the solution shop. And I'm going to go through a list of what I think are really important, interesting concepts, and you pick which ones you want to respond to. That's one that in the work that we are doing here at Arizona State University, that's just coming up more and more and more in terms of the 3 models of Clayton Christensen with respect to disruptive innovation. Your work in the Hospitalist is so important. I remember in the early 1990s when I'd be in the office and throughout the course of a day I'd see 50 or 60 different internists leave the clinics and go several miles to the hospital for all the reasons you were describing, patient crashes or something unexpected happens and they need to cancel clinic, rush over to the hospital after they've made rounds in the morning before clinic, and then they go back to the hospital after clinic. It's just it's unworkable. And so the Hospitalist program is a real important program, but as you were pointing out, it's also it needs to continue to be perfected. when we tried to implement our hospitalist program, it took several years, and our physician said, over my dead body, is anybody going to see my patient, because it's my patient, I know the patient, and they were really concerned about continuity of care. After several years of having this hospitalist program, our medical director asked them again, do you want to continue it? And they said, over my dead body, will I ever not have this hospitalist program? So, David, that gets to a question that you might want to comment on. You mentioned the 3 aims, but how does all your work, especially the hospitalist program, affect the 4th aim? There's absolutely no question that it improves the joy and the work life of physicians, although there are costs associated with it too, non-economic costs. Another interesting topic that you raised, David, which is related to that is, I think, that we've got the 21st century technology, but we still have 1915 level care systems. And I think throughout all the work you are doing, you are addressing that concern, which is how do we get our care delivery design from the macro level all the way down to the micro level into the value proposition and the value equation. So, David, I'm going to pause there. I'll give you one more question. In terms of the 25% of the patients that are 85% of the cost, the work that we've done, first of all, again, that's so important, is that population of 25% of people does not tend to stay the same, that it rotates, especially in a Medicare population, is because a lot of that population divides within a year or so, the numbers in terms of the last 6 months of life. So those are all really important concepts that you touched on in your presentation. Would you please feel free to elaborate further on any of those that you would like to? So you can decide which ones you want to elaborate further. Again, thank you very much.
Oh, thank you, Bill, for your kind comments and great questions. I think the solution shop idea is a critical and very interesting one. I think the trick is, where do you focus and on what do you focus? And I do think that there's something special about focusing on these people in and out of the hospital, because it is a group where that is so, there's so much expenditure and so much discontinuity. But it may not be the only solution shop that's the answer, and I do think it's interesting to think what others would be. I think that one of the advantages of this defragmentation is strengthening the relationship, again, between the doctor and the patient. And the not over my dead body transition comment you made is fascinating. And I do worry that the more we sort of fragment responsibility, we weaken the willingness of clinicians to really invest in patients. And I think the power of those patient relationships is probably the most important driver of professionalism that will ever be out there. And I worry we are weakening that. I wanted to spend just a minute more on your comment about the 25% sort of rotating through different years. And I think you're right about that. What I will tell you is it's not a completely different 25% every year. It's there's a lot of overlap over time in that. But in fact, I think that the overlap, the fact that group does change to some extent over time, is actually an argument for the CCP model. One of the things that happens is that if you have a group that's high utilizer this year and you assign them a care coordinator, for example, it's pretty unlikely that care coordinator is going to be available and kind of come back to them again over time. And they tend to be assigned short term because they're very costly. One of the beauties of the CCP model is that it's actually not a costly approach to care coordination. It's a lean, in fact, I would argue almost free approach to care coordination. And the beauty of this is that you do not need to kick people out when they get better. You just become their primary care doctor. And as long as you have enough patients who are high acuity in your model to justify being in the hospital, you can continue to have them in their model. And as we've gotten smarter at this model, we've realized that the vast majority of hospital volume is driven even by a sub-fraction of this population, and it's actually not that difficult for us to keep these doctors busy in the hospital. It has practically worked out very well in our setting. So we've thought a lot about the issue that you've described with the sort of changes over time, but I think actually it's worked out very well for us. So let me stop there.
Yeah, before I turn it back to you, Bill, I think it also segues into just one of the questions that we had from our audience from Susan Bentler, who asked, David, how did you estimate the high-cost users, particularly for that particular metric?
Yeah. So to be technical about it, our goal was to seek patients at high risk of hospitalization. And they are high cost, but our goal was to find people who would be hospitalized. And in retrospect, it may be obvious, but it turns out the best predictor we found of who's going to be hospitalized in the future is who's going to be hospitalized in the past. And so we ended up having a relatively low threshold, which is that if you're a Medicare beneficiary and you've been hospitalized once in the past year, then you're eligible for the program. In reality, what's happened is that the people who've been interested in the program have tended to be the people who've been hospitalized multiple times. But we will allow people in even if they've only been hospitalized once. And our inpatient volume has just fine. The doctors are not bored in the morning, nor are they overwhelmed, and it's managed to be economically viable. But what I think is most important there is that someone managing a program like this could, through relatively simple decisions, tighter up or tighter down the inpatient volume relative to the ambulatory volume to make this model work. So we have a lot of dimensions for flexibility.
Correct. Well, I think I echo what Bill said. There was just so much to digest. That's why I think our audience members who would like to ask questions, if you don't get your questions today, we'd be more than glad to forward them to David. But I think we still have a few more minutes. Bill, I think you might have some more questions for David.
Yeah, David, you're absolutely right about that 25%. Sorry, I misstated it. Yes, there is overlap. You know, the numbers that we've seen over the years is it's like 10 to 30% of that population might transition. But your points are very well taken, and I think that perspective you followed up with makes total sense. David, how about you are having a lot of impact on the fourth aim, you know, just in terms of the satisfaction for providers. So could you comment on that? What do you think about that, and what do you think, if you do agree that it's helping to address the fourth aim, what is it that you are doing that's accomplishing that?
Yeah. So, you know, I think that the physicians involved in this program get a lot of satisfaction out of having, you know, ongoing relationships with their patients. And that's true, I think, not just about the physicians, but about the other members of the clinical team. You know, these are actually some of the most challenging, complicated patients in the system.
Yep.
They're the patients who very often, for other doctors, are sort of pretty negative experiences, partially because the doctors' practices are not well set up to meet their needs. I think that one of the things that, you know, when we look at patient satisfaction scores, it's very clear the patients are very happy with their doctor and feel very devoted with them. I will share one thing that we do sometimes that's been really nice. We used to do it every week, but now we do it about once a month. We take comments from our patients that were told to our clinic coordinator, and we present them to the whole team in an identified way so that they can hear what their patients are saying about them. And the patients are amazing. Some of the words that they use to describe what these physicians' care mean to them are just genuinely inspiring. And so I don't want to minimize that these are very complex patients and that, you know, we're in a resource-constrained environment and that, you know, sometimes things are hard, but there is this countervailing immense gratitude that comes from patients for what they perceive to be care that truly cares about them, and I believe truly does care about them. And I think that sort of, you know, is a critical part of that fourth aim. I'll also say that, you know, we have a very closely knit team, and that there's a lot of mutual respect and support of providers of each other. And you know, it's like a family in some ways, and there are, you know, times when there are challenges, but, you know, people work things out, and there's a lot of support. And I think this has implications for growing a model like this. We've thought about growing here at the University of Chicago. Right now we have 5 physicians and then the other members of the team. If we were to double in size, I would not create a team twice as large. I would create a second team of exactly the same scale. And the reason is that intimacy, this idea of a clinical microsystem, I think is critical. That sort of fourth satisfaction.
Thank you. Thank you.
All right. Well, thank you so much, Dr. Meltzer. And I think a lot of people would want to learn more about the program. And I think a good first stop would be the website S4A. But definitely, they'll be looking forward to hearing more updates from your program. And echoing what Bill again said, thank you so much for that excellent presentation. There's so much to digest. And thank you so much again, Dr. Meltzer and your team, for your time today and your presentation. Also, thank you, Dr. Riley, for also taking the time for providing the commentaries too as well. So we'd like to also, again, let everyone know that today's webinars will be available for download, and the recording will be available for download. And so please take a look at our archive at the S4A. And also we invite you to our upcoming webinars that will also be led by Dr. Riley and his group too as well, research team. And we look forward to having you there. So again, thank you so much, everyone. Thank you, Dr. Riley. Thank you, Dr. Meltzer, for your time. And we wish everyone a good day.